They're the main things.
Okay, and can you can anyone explain the high lactate to me? Why does this child have a high lactate? What could be the mechanism of that?
So we've got a couple of answers: post-seizure status, poor perfusion, hyperperfusion with sepsis, septic shock, hyperperfusion post-seizure, still seizing.
Okay, good. So she's very lactemic. Have you, as anyone from the audience, there's nearly 100 of us in the audience, has any of you seen a lactate of more than 5 on a child with a prolonged seizure? Is that in keeping with a standard prolonged seizure, even if it's a febrile seizure?
Yeah, most people have wrote yes.
Okay. I would say that usually anything above 3.5 in a child with status, unless the seizure has been for a good 2 hours or so, you are unlikely to get lactates more than 3.5. So lactate of 5, 5.2, which Chloe had, is on balance probably outkeeping with a basic status epilepticus. Okay. Her potassium is on the higher side. Is that significant? And why do we think that high potassium has happened?
Muscle spasm, rhabdosesthesia.
Yeah, good. Anything else? One more. I'm looking for one more answer.
Not yet.
Okay. So a few people said she could be septic with that temperature.
Acidosis and head injuries just come in as well.
Okay. Okay.
Toxin.
So with sepsis, what happens to the kidneys if she's septic? Good. I like the acidosis. So acidosis drives hyperkalemia. So acidosis drives potassium extracellularly. So acidosis can be significantly contributory to the hyperkalemia. That's good.
AKI secondary to poor perfusion.
Brilliant. So that's what I was looking for. So she's got a few things to cause that potassium to be on the high side, and we'll get to that, why that's relevant in due course. Okay. So she's got a combination of possibly rhabdo. She's very acidotic, driving potassium extracellularly, and she is septic, so likely to have a degree of AKI. Okay, so this is where we try and solve this riddle, which was a true case together. So we'll do a number of questions focusing on A, B, C, D, E, F, G, and there's 96 of us in here. I'd expect at least 80 of you to answer before I move on each question. So if you scan this with your phone, or if you don't have a phone, go onto Slido and type that code in, and then you'll be able to see the poll. And I'll change my screen in half a minute or so, whilst to give you a chance to get onto Slido, so you can see my screen as well. Oh, go back. People are answering already. Okay, so let's start with the airway. So what is our airway plan? I'll try and make the screen a bit better. Remember, this is anonymized, so feel free to answer. There's no one's going to know what you put down. This is purely for your learning. So take a gamble. So we've got nearly 50 of you answering. I need at least 30 more. Keep going. You can change your answers if you're unconvinced as well. So. Okay, when we hit 60, I'll start discussing the case. So 8 more, please. Okay, so we've got 55, 56, not bad. So we think, so lots of people think this child has status epilepticus, which she does, because she's been fitting for an hour. So what does APLS say we should use for children in status epilepticus? Can someone type that in the chat room if they remember? So what anesthetic agent and what paralyzing agent does it say on APLS before the latest update? People posting?
They've got Thio
Yeah.
and Stux.
Okay, Thio and Sucks. So that's what APLS has historically said. So Thio and Sucks. So we're worried this child is septic. So is Thio a good idea? What physiological effects does Thio have to us if we give a big slug of Thio to even a stable patient? What does Thio do?
Hypotension.
Okay, good. So in the context of the child who's 6 and she's got a diastolic blood pressure of 42, is giving a big slug of Thio a good idea? No, I see people changing their answers. So Thio, so this is where it's important to use our thinking hats and to not follow dogma just because it's dogma. So the DGH would have been within the right to say this is what the guidelines say. We want to give Thio, but we need to treat the context and not based on a protocol. So protocols are there to guide us and not to, but we have brains which we need to engage. So giving Thio to Chloe would cause, without a doubt, an arrest. So there are better, less cardio unstable drugs to use in this context. Okay, and ketamine is increasingly preferred by transport teams because it doesn't have as much vasodilatory effect as all the other stuff that we tend to use, things like propofol, thiopentone, or gaseous induction. And the reason I'm saying this to you, because there's a mixture of pediatricians and ED docs, is because it only takes one person to think of this and be empowered to speak up in a team. We're all responsible. And even though this is ownership of the anesthetic team, sometimes if the anesthetic team are task fixated, it's up to us to flag it up. So don't stay in silence and not saying what you think is safer for this child. At the very least, you should try and mention it and speak up. So if you see a child who's hypotensive or septic, thiopentone and propofol are very bad ideas usually, especially if you do not resuscitate before you intubate. Okay. So ketamine would have been the right answer in this context. Then we move on to the choice of paralytic agent. So we said APLS also suggests Sucks. What side effect does succinylcholine have?
Hyperkalemia.
Excellent. So Sucks can drive potassium extracellularly. So with a child in AKI with rhabdomyolysis and already borderline potassium, giving Sucks may precipitate a massive potassium surge and cause a hyperkalemic arrhythmia or a hyperkalemic arrest. So Sucks in this context would be an awful idea. Okay, so first of all, do no harm. So choose your drugs safely. Because it's a child, there's always a bit more panic in ED, both from the anesthetic team and the ED team. That's human nature. So it's down to us to make sure that we speak up and say to the anesthetic team, well, maybe it's better to give something else that is not going to cause a potassium release. Okay. And then the final choice is a difference between cuff tube and uncuffed tube. Now, this is part of pattern recognition in emergency care and critical care. We need to know the illness in order to beat the illness. So we know this child is likely to be septic. Children with sepsis get significant vascular leak. They need lots of fluid. They struggle to keep that fluid intracellularly. So they tend to get a fair amount of pulmonary edema. To ventilate the children effectively, you need to make your best tube, the first tube, your best tube, because having to reintubate her is usually a bad idea because every intubation process comes with a significant risk of an adverse reaction such as arrest on induction, okay? And the benefit of the cuff tube is that it forms a nice tight seal within the trachea and allows you to ventilate a lot more efficiency with a lot less pressure leaking around the sides, which is what you can get with a cuff tube that is slightly undersized. And you can adjust that cuff pressure as you wish in a way that's safe for the patient. So if a child is very sick, we're increasingly preferring cuff tubes in PICU. If you're a pediatrician, most of your critical care training has come from neonates, where cuff tubes are not mainstay, but that's because it's a different population. So a very preemie baby will have fragile tracheas that could be damaged. A term child and above doesn't. So you can use cuff tubes safely, provided you don't overinflate them. Okay, so make your first tube your best tube. Good, so well done to the 72% that answered correctly. Let's go to the next question. So what is your best breathing plan? Okay, so like we said, this child had pulmonary edema. Pulmonary edema is frothy, pink and bloody in nature. And she was very, very difficult to oxygenate. She had, you know, even on 100% oxygen on high pressure, she had SATs between 70 and 75. So in context, what sort of pressures would you try and deliver on the Hamilton, and what else would you do? Okay. Most transport teams are able to give nitrate, by the way. We don't use it very often, but we do have the capability to use it. I'm not saying that's what we did, but just so you're aware. Okay, I've 40 answered. I need at least 10 more answers. Remember, it's anonymized, so no one's going to laugh at you. Three more, come on, humor me. Okay. So, so the top answer is pressures of 30 on 5. That is not entirely correct. So remember, we need to know the illness to beat the illness. So this child is septic. She's going to get pulmonary edema, and she's already not oxygenating. And I think it's telling that I am delivering this to mostly a pediatric contingent that by nature of their training are exposed to neonates where they have low PEEPs. We're a lot less PEEP phobic in PICU, and we know for a fact that children with ARDS have better oxygenation if you over-distend the alveoli. There's lots of reasons for that, but the simplest way I explain it is the alveoli are overstretched. Therefore, the alveolar membranes are much thinner. Therefore, the distance that oxygen has to diffuse through to be absorbed by the pulmonary vasculature is a lot less. So oxygenation becomes a lot more efficient at higher PEEPs. Now, higher PEEPs come with a risk of getting a pneumothorax, but a PEEP of 10 will rarely give anyone a pneumothorax. And I can tell you that we ended up going on a PEEP as high as 14 on Chloe to try and oxygenate it, because even with a PEEP of 10, we weren't able to oxygenate it very well. Lower PEEPs are associated with atelectasis and terminal atelectasis, which causes atelectasis trauma. And if you think of your bog standard party balloon, the hardest part, the most energy expenditure needed to blow up a party balloon is that initial phase when it's fully deflated. So if you think you're doing that to the alveolus by having a very low PEEP that allows the alveolus to fully collapse before they reinflate, you're causing a lot of shearing damage and natellar trauma to the lung. So a PEEP of 5, especially in a child with very bad ARDS, is generally a bad idea. The respiratory rate is consistent, it's age relevant across all the answers. So that needs to always be matched to the age. So for her, it was 18. And we opted for a higher eye time on her. And again, the reason for a high inspiratory time is, again, to allow better oxygenation. So the higher the eye time, the better the oxygenation, because oxygenation happens during the inspiratory phase of the respiratory cycle. That comes with a knock-on effect of having a smaller expiratory time. So you have the risk of stacking CO2 and retaining CO2, but children don't die from CO2 retention. Children die from hypoxia. So on balance, that's a risk we need to take. Now, she needed 100% oxygen. She had lots of secretions coming up. Most of them were bloody. We did use tranexamic acid and we did use adrenaline nebs for her. Now, adrenaline nebs, I bet you're all accustomed to for croup patients. It's the same dose. If you've looked after children post-tonsillectomy bleed, again, it works very well for tonsillar bleeds. But tranexamic acid is less well known in the literature, but it's increasingly being reported, and it's a safe drug to give. It's got a very narrow side effect profile. Remember, this is nebulized tranexamic, not IV tranexamic, because in the context of sepsis, IV tranexamic acid is slightly contraindicated because it affects platelet aggregation and could make matters worse. In the context of sepsis, it can make DIC worse. But nebulized is absolutely safe to give. And the doses in the literature, and they're easy to remember, is 250 milligrams nebulized for children 25 kilos and under, and 500 milligrams nebulized for children 25 kilos and over, which then brings us to nitric. Now, can anyone tell me what nitric does systemically? What effect does it have on our patients when we give it? Physiologically, how would it affect? What would it affect? What would we see on our monitor? Oh, okay, lots of clever people saying vasodilation. Excellent. So on a child who's got a pulmonary edema and possibly bleeding, do you think vasodilating them is a good idea? No, good. So we didn't use nitric, and I think we were validated for not using nitric. It was, in retrospect, the right thing to do, because it was tried on the PICU after we arrived, and she arrested briefly on it. So I'm glad that didn't happen in the DGH. So always be wary when you do an intervention. You need to know the side effects of that intervention. So I think giving nitric to her in a small department with no support would have been a bad idea. So we opted not to give nitric because it would vasodilate her, would make her more cardiovascularly unstable. Plus it would, because it's a non-selective vasodilator, it doesn't just vasodilate pulmonary vessels, it also vasodilates systemically. It was likely to make the bleeding worse. And I've seen that happen numerous times, especially in children with drowning. Okay, so the correct answer, like people have just changed all their answers, is what's now top of the screen. So pressures of 30 on 10, eye time of 1.2, 100% oxygen, tranexamic, and adrenaline nebs. Okay. Any questions so far?
There's a few questions about nebulized tranexamic acid. and whether it's only used for pulmonary edema and other people have not really used it before, so wanted to hear a little bit more. If you
Yeah,
have.
so that's a good question. And so the evidence initially came from adults with hemoptysis, adults with TB or lung cancers. And then it gradually started creeping into children post-tonsillectomy. The side effect profile is minimal. The contraindications are minimal. There's no contraindications for nebulizing tranexamic. And anecdote, I've used it a number of times and it tends to work really well. Can I show you a big RCT that's been done? No. Does it work when you're on the shop floor? Yes. It's not just indicated for pulmonary edema. Any sort of upper airway bleeding, there's absolutely no harm in using it. And I can share the evidence with you and the papers with you at the end of this if you would like. I can email them to you. I'll send them to Josie. Okay.
And there's another question about high PEEP affecting cardiac function in this hypotensive child.
Yeah, so that is a balance. We're coming to the circulation part now. This child needed, well, technically 5 inotropes, and she's already hypotensive. So she needed a lot of filling and she needed a lot of inotrope, and that's what you need to balance. And it's not always easy, but we know that if we let her be hypoxic much longer, she wouldn't survive. We can always try and push the blood pressure up by mitigating with fluid status and pressors. And that's the nature of the beast. But that's a good question. Anything else before we move to the next one?
No, that's it. Thank you.
Okay. So let's move to the next question. So on to C. So this child is hot, so she's in warm shock. So we need to decide what our best circulation plan is in warm shock. So what would you do for her? And remember, the guidelines have changed from the Research Council recently. Okie dokie, 45 of you. So let's see what you've put down. Good, looks like you know your algorithms. So she's in warm shock. So what I would say is the following. Lots of people like talking about inotropes. Lots of non-intensivists get scared about inotropes, and we shouldn't complicate matters to ourselves. When a child is needing 40 to 60 mL per kilo of fluid, and I'll come to the choice of fluid in a minute, we know that we need to start thinking about inotropes. It's very hard to make matters worse with inotropes if you choose one of the 3 commonest ones. Okay, so if you use adrenaline, dopamine, or NORAD, usually you're doing something right. The inotrope that is the most safe to use in every situation, if you're in doubt, is adrenaline. And there's increasing evidence now to show that we can use adrenaline, diluted adrenaline, peripherally. Okay, if this and a child as sick as Chloe, really there's no excuse not to have an IO in situ. Okay, to use as a central line. Sometimes they need 2 IOs for the amount of drugs they need. But if in doubt, you cannot go wrong by using adrenaline. Now she is in warm shock. So the purists will say that she needs NORAD first and vasopressin second, with adrenaline and with a steroid, which would be correct. Okay, so the purist's answer would be what you have all put down on top. Okay, but don't get your knickers in a twist if you're not sure. There's always a friendly intensivist down the phone, which depending on which region you're in, to guide you. But if in doubt, and if it's likely to cause any delay, just start peripheral adrenaline. If you're more comfortable with dopamine in your department, because that is still common practice in the UK, please start dopamine. So an inotrope early is better than no inotrope early. So that's the most important take-home message for today. So start something early. It doesn't really matter what, because the studies comparing non-inferiority, which one is superior between dopamine and adrenaline in shock, give a very slight advantage to adrenaline. So and intensivists like to make you feel, that you're not up to date with current evidence by saying, oh, we need to use adrenaline and dopamine is an awful drug. And it's not really that starkly different. So if you're comfortable with dopamine, use that. If you're in doubt as to what to use adrenaline. If the child is in warm shock, and we know that 1 in 3 kids are in warm shock, by all means, you can get the NORAD out, and that too can be used peripherally, but with slightly more side effects if the child is, little, under the age of 6 months or so. Which brings us to our fluids. I'm delighted that people have put Plasmolide or Hardmans on top of the list. Okay, now we know Plasmolide and Hardmans have potassium in. Can anyone tell me why it is still safer to give balanced solution in a child with hyperkalemia rather than saline, or abnormal saline, as I call it? Yeah, because you will be challenged in ED. They'll say, "Oh no, doctor, this Plasmolide has potassium in, and this potassium is 5.2 in the child, so you're just going to make things worse." So what can you tell them to mitigate?
There's too much chloride in normal saline, so risk of acidosis.
Good. And chloride then drives what? So what does chloride do to our pH?
Acidosis.
Yeah, so basically, there's a number of reasons why Plasmolide and Hardmans are better in an acidotic state, okay? Plasmolide and Hardman are basic, yeah, they're base, whereas saline is acidic, okay? People will say, oh, it's Ringer's lactate. Hardman's is Ringer's lactate. It's got lactate in it. It doesn't. The lactate in it gets metabolized into bicarbonate buffer by the liver. Okay, so Ringer's lactate, which is the same as Hardman's, gets metabolized to bicarbonate, therefore making our pH more alkalotic. There are alkali solutions that therefore push our pH up. If a pH is more alkali, then by default, potassium moves intracellularly where it belongs. If we give saline, which is an acidic solution, would cause a hyperchloremic acidosis. That drives potassium extracellularly, making hyperkalemia worse, even though the child doesn't have, even if the child didn't have hyperkalemia. Okay. The other thing I would say is the concentrations of potassium in Plasmolide and Hardmans are minute. So you can never, other things being equal, you can never cause a solution to become more concentrated by giving a more dilute solution. Yeah. So if you have a child with a potassium of 6, if you give a solution with a potassium of 3 in it, you will not make that child become more hyperkalemic because you've given a more dilute solution. Okay, there's a paper that declaration of interest, which I wrote in archives a couple of months ago on how to manage hyperkalemia in a sick child. Look it up, or I can share it with Joseph to share it with you. It's a very simple step-by-step approach. and it does sing the praises of plasmolite and Hartmann's in context, but we need a culture shift into using saline as the first line in shock. And indeed, that's been provided by the Research Council a few months back, which said the best fluid to give in shock, with the exception of trauma, where the best fluid is blood and blood products, is balanced solution, so plasmolite or Hartmann's. And if you don't have anything else, then we can opt for saline. Okay. Now, steroids and sepsis are controversial. Current best practice says once you reach the 2 inotrope mark, so if you're on NORAD and vaso at the same time, if you're on dopamine and adrenaline at the same time, whatever, once you reach 2 inotropes, then you need to add hydrocortisone in, because you're in the realms of steroid-resistant shock. So you need to replace whatever steroid that child is missing. If you have the wits about you and your presence of mind, you could check a baseline cortisol level. It's not the be and all and end all. It's not going to change management, but it would be useful later on when we unpick the case to see whether the child had a cortisol deficiency secondary to sepsis. Any questions? A plasmolite is not too expensive. It's cheaper than saline. So my old trust have actually made savings by replacing saline with plasmolite. That's one of the questions. By the way, I don't get paid by Baxter, which makes plasmolite. There's no conflict of interest there. You're welcome, Catherine. Anyone else?
No other questions.
Okie dokie. Now, people ask about the papers. I can't really share them on the chat room. I don't have them here, but I can email them to Josie, which can share them with you if you want.
Yeah, we'll get them sent out after.
Yeah. Right. Moving on. Disability plan. No, remember, Chloe banged her head on her way down when she was falling with a seizure. Now, you've had an earlier talk about oxygenation indices and when an ARDS is really bad. So I can tell you Chloe's oxygenation index was in the high 40s. So does anyone know what that means if someone's oxygenation index is in the high 40s? Is that good or bad? So she was on a PEEP of 14 or so, 100% oxygen. Eye time crept up to 1.5 or thereabouts eventually. So what would that mean? What is her best chance of survival at this point? Why am I banging on about oxygenation index? Yeah, well done, Laura. So a high oxygenation index. I'm not going to share the formula here because they were shared in the earlier presentation. Means that we need to consider ECMO. Okay, so there's only a handful of places in the UK that do pediatric ECMO. So taking her to a standard ITU that doesn't provide ECMO would probably prove fatal for her. So she needed to be discussed with a local ECMO center. But because of the nature of ECMO, where children are heavily heparinized to stop the filter from clotting, if she has pre-existing head injury, she's likely, that is significant, she's likely to not be eligible for ECMO because ECMO is going to cause our bleed to expand and be a pre-terminal event, okay? Which is why she's likely to need a CT. So we need to decide whether to CT her before we set off or after we set off. At this point, our patient is on 5 inotropes, essentially, very low blood pressure, very high ventilatory requirements. And we had to wake up the CT person to come from home to unlock the room to let us in. Okay, so would you CT her before or after? Okay, give me a few more answers. There's 45 answers. Give me 50. Come on, humor me. Okay, so neuroprotection is correct. So what do people understand by neuroprotection? There's a few sort of facets to it. So what do people understand by that?
So 30 degrees head up, normocapnia,
Yeah, good,
normoglycemia,
good.
basically normal everything. Most people elevating the head of the bed, and preventing high fevers as well.
Good, high normal sodium, good, good BP, great, fabulous. So clever bunch. And I'm hoping there's a combination of pediatricians and ED people, because ED people are usually quite good at neuroprotecting, whereas in pediatrics we sort of glaze over neuroprotection quite a lot in APLS. There isn't a good enough section in it, I don't think. So neuroprotection is easy, and we need it in every child who's had an arrest. We need it in every child who's as sick as Chloe. So we're very good at doing CPR, but we're not very good at post-arrest care until the transport team comes. So we need to become better at it, because it's not difficult. It doesn't take an intensivist to do a good job. So the basic things that we can get right is having a high normal blood pressure, although in the context of trauma, I understand that if you have it slightly higher, you might make the bleed worse. But at the very least, have a normal blood pressure. If you don't have trauma, have a high normal blood pressure. That allows adequate perfusion to the brain. Now, brain needs sugar. You cannot let this child become hypoglycemic. Okay. The fact that she needs steroid already suggests a degree of steroid deficiency. So keep an eye on the blood sugar. Keep doing them every half an hour or so, okay, which you would do anyway with your gases. Keeping the head at 30-degree angle is important. That is deemed to be the optimum angle to get enough blood up to the brain, but enough decompression of venous return back down without making things worse. So always have the child slightly at an angle if possible. Okay. Now, normocapnia, what we mean by normocapnia is a PCO2 between 4.6 and 4.8, ideally. Okay. And trying to avoid the child from becoming hypoxic. If you feel that child is having Cushing's triad, so hypertension and bradycardia with abnormal respiration, which you wouldn't know in her because she's already paralyzed, then you need to be thinking of pushing that sodium up. So you can give 3% saline as boluses, 3 to 5 mL at a time to try and push that sodium up. Okay, now remember, 3% is very chloride rich, but on balance, to stop her from coning, you would need to do that. And indeed, she needed that to be done. Okay. Also remember that if people have used atropine during the intubation to push the heart rate up, which is something I don't approve of, you're not able to see if this child is fitting. So she might be paralyzed and still fitting be under the paralysis. So you need a long-acting anticonvulsant on board. Now, assume she hadn't had phenitoin, a child is unstable with all these electrolyte imbalances, what would be the best choice of anticonvulsant to neuroprotector? Keppra, excellent. 10 points to Gryffindor. So Keppra has been shown by 2 good quality RCTs over the last 2 years, the ECLIPSE trial and the concept study, to be non-inferior to phenytoin. That means they both work well enough, but you can bolus it, so you don't have to wait for 20 minutes. So someone who gravitates to ED or intensive care are by nature impatient, so that we just like to give it. And it doesn't cause arrhythmias, which is a problem with phenytoin. So just give the Keppra, okay? That is, something you can do to minimize risk of seizures, especially if the child is paralyzed and you can't keep an eye on whether the child is having seizures or not. And the problem with atropine is that it causes miosis, so the pupils are fixed, so you can't tell if they're fitting or not. So in the context of that, or a child like that, I wouldn't ever give atropine for intubation. I will use dilute adrenaline. We can come to that at the end of this time. Okay, morphine and midaz is what the standard we use in our children. We wouldn't use propofol mainly because it causes a lot of vasodilation and it would cause more inotropic dependence, and also children are more likely to get a condition called propofol infusion syndrome, which makes them very, very acidotic, which is something we're trying to avoid. And we did have to brave it and get a CT done prior to transfer. It was very hairy. She did become very bradycardic in the scanner, but she survived it, and she didn't have any further intracranial mischief, which was good because that made her ECMO eligible. But without the CT, she would have been refused for ECMO, and the ECMO center was significantly further away than the closest ITU. So it made a big, would have made a big impact on our plans as to where to take her. Okay. Any questions at this junction?
No.
Okie dokes. So next slide. So so she's septic. Remember, she went in with a sore throat. She got a temperature of 41. What do you give? What's your best antibiotic choice? Okay, be 5 more people gone. Okie dokie. So remember, she went in. So most of you said Kef and Clinda. Some say Kef alone, and some say Kef, Clintine, IVIG. She went in with a sore throat. GP sent her out to get Pen V. She didn't quite make it to pharmacy. What is the likeliest pathogen in this setting? Well done, Sarah. Invasive group A strep. Sarah Wills gets the brownie points. So that was the likeliest pathogen. Yeah. So group A strep is toxin releasing. So she has toxic shock syndrome, okay, which you see in group A strep or any toxin releasing organism. You get it with staph, you get it with patients with burns. So you need, at the very least, to give Kef, but you need Clinda to mop up the toxins. That augments toxin release and mops toxins up. Okay, so never ever forget Clinda in a child who is as septic as Chloe. So high temperatures, toxic looking children, which is what she did look, very, very hot children need Clinda as well. Okay. Now, once you reach the 2 inotrope remit, you know that you are in the realms of inotrope resistant shock. And that is one of the indications to give IVIG, because IVIG is very, very good at mopping up those toxins and changing the course of the disease. Now, it's increasingly harder to get. A combination of supply issues, Brexit, and the Americans holding on to it a bit more. But it does, there's some evidence to show that it does make outcomes better, okay? It's very anaphylactogenic, so it needs to be given slowly, don't bolus it in. But it's very hard to get hold of, and each trust has its own policies. So you need to know where those policies are, you need to know where it's stored, and you need to convince the gatekeepers, because it's very expensive, to give it to you. So make sure where the IVIG policy is in your trust and how to get it in the middle of the night when it's usually needed, okay? There's an even bigger shortage of it because of COVID now, because lots of the adult COVID patients are getting it. Okay, so if you are looking at a child with toxic shock needing lots of inotropes, think of IVIG. Now, in about 20 years ago, before the pure version of IVIG was available, what else could we have given, or what can we still give in our setting to have a similar effect to IVIG, albeit at on a weaker concentration?
Methylpred.
So methylpred, so you can give methylpred as part of the steroid, although she got Dex.
Plasma exchange has also been offered.
So not plasma exchange, but plasma is the right answer. So Mohammed got it right. So FFP used to be given instead of IVIG before the purified version because it has a weak level immunoglobulin in. So if you can't get IVIG on a child who is likely to be coagulopathic, because we know sepsis causes significant coagulopathy, and a child who is going to need lots of volume, and we need to make our volume useful volume. So don't just bang in plasma light or saline. Think of blood products, because she's going to be anemic because she's bleeding, she's hemodiluted, and she's also coagulopathic. So have a low threshold to give blood products, including blood, FFP, cryoprecipitate. Treat these children like a major hemorrhage. If you don't have, if you haven't cross-matched them in time, if it takes forever, just, if you're not cracking the major hemorrhage protocol box for this sort of patient, I would suggest that you move your red line to include these patients, because time is of the essence, and giving them useful volume, as I call it, will change the outcome and the prognosis. Okay. So what we gave Chloe was Kev, Clinda, and a very, very good general pediatrician managed to get IVIG out of the vault for us, which really make a difference quite quickly on her. Okay. So I will go back to my presentation if I can figure it out. Stop share. And this is basically a quite useful slide. You can screenshot it if you want. Now, I've talked about the evidence shift towards adrenaline in the northwest of England, where I've come from. Dopamine is still top dog. That needs a culture shift, and we've talked about adrenaline being the best first choice. But most children have cold shock. If you've got cold shock, it's safe to start adrenaline first, and then aim for mixed venous sat of more than 70% and an HP of more than 100. And then if you have warm shock, which is about 1 in 3 children with shock, then the best first choice is NORAD. Then you can add vasopressin in. I would never start milrinone on its own first, no matter what. So that can be a very harmful inotrope in the wrong hands. So you need intensive care to be present, because if the child is already vasodilated, then you are likely to precipitate an arrest. So choose anything from dopamine to adrenaline ideally, or maybe NORAD if you're comfortable with your ITU skills, but try not to use milrinone as first choice on its own, because it can make things a lot worse. Okay, so this is what we did with Chloe. I think I forgot to mention calcium. I'll talk about calcium in a minute. So we used our CAFD T-tube, we nebulized tranexamic and adrenaline. We used the high PEEP strategy, ending up on a PEEP of 16 in the end to try and get her safely to the ECMO center. We had a very long eye time. We avoided nitric, and we recognized that she needed ECMO. She was on all those tropes. Now, calcium is important, and it was on the gas as she was hypocalcemic. Now, critically ill patients tend to drop their ionized calcium very quickly. Now, you need to go off the ionized calcium and not the lab calcium, because that is the calcium that is useful to the myocardium. Calcium is the hidden inotrope, and it's also very useful in the coagulation cascade. But please don't make me explain the coag cascade for you, because I can't remember it. So always make sure that your ionized calcium 1.1-ish if the child is critically ill, because that will support the myocardium really well. You cannot have a good blood pressure with hypocalcemia or with extreme acidosis. The myocardium just doesn't work well enough if you're really acidotic or if you're really hypocalcemic. So always keep an eye on the ionized calcium on the gas. And if your gas machines don't do it, ask the lab to do an ionized calcium for you. Disability-wise, we did a CT. It was a bit hairy, but it was fine. Keppra, morphine midaz, and she needed 1 bolus of 3% because we thought she might be Cushing's in the scanner. We gave Kev, Clinda, and IVIG. It was sort of arm twisted to give in a cyclovir because we weren't quite sure what we were dealing with. And then she gave, that's not a typo, she had 260 mL per kilo of fluid, a combination of blood, FFP, platelets, abnormal saline, which had been given before we got there, and plasma light. So this is Chloe on her 8th birthday, so 2 years after this. She came off ECMO on Boxing Day, and she's riding on a unicorn. And I would say that we couldn't, this picture could not have been taken, would not have been possible without the amazing teamwork we'd had at the DGH, from the nurses that worked their socks off alongside us, to the porters that virtually run a marathon that night, running to transfusion lab and to the biochemistry lab with various samples back and forth, and the amazing consultant that managed to get some IVIG for us. But perhaps more importantly, not without the help of the adult ITU reg, who stayed with the family throughout to update them on what was happening, how Chloe's clinical condition was, and to keep them updated. I would probably say that was the most significant intervention that we did on that evening. Because remember, this sounds very stressful to everyone. This case, was quite a nasty one. So it was a bad day at the office for us. But without a doubt, it was probably the worst day in that family's life. And Chloe's family, we're not ever going to remember what inotrope we used or what antibiotic we used or whether we used IVIG or not. But I can guarantee you families like Chloe's would remember how you made them feel and whether you have kept them updated or not. And that's all I have to say. I'm open to any questions. Thanks.
So there was just one question. So the question was, given the initial presentation of a prolonged capillary refill time, hypotension, tachycardic, but with hypoxia, would you wait for the perfusion to improve before you do the induction and intubation?
So I don't want to turn this into me showing off my papers, really, but I again, a few months back, I've had a paper out on, or in archives again, on the intubation of the critically ill child in the emergency department. And in that paper, I talk a lot about resuscitation before intubation. So there's lots of tricks to do to mitigate the risk you've just very eloquently explained in your question, that if you intubate a shocked child, there's a risk of them arresting on induction. But the way to mitigate that is to give adequate volume before, and to start peripheral inotrope beforehand. So you can have dilute adrenaline running through a cannula or central strength adrenaline running through an IO to push that blood pressure up. You can give adequate volume beforehand. And you can also draw up some dilute adrenaline in a syringe. And what I mean by dilute adrenaline is taking the resuscitation dose of adrenaline and diluting it in a 10 ml syringe with water for injection or saline. And then we can give 1 ml aliquots, so essentially 10% of the research dose, when we see the blood pressure drifting or the heart rate drifting. And you empower your nurse to do that. She's watching the monitor as you're intubating. Your focus is on the cords, and you've told your nurse, if this happens to the obs, just give 1 ml at a time with a flush. And that got me out of a hole lots of times. But this needs practice, in simulated practice, and in theatre to get it right, which is why I always say, if you're doing PEM and pediatrics and anesthesia, you should always try and come for a stint at PICU where you can learn all these tricks of the trade. But I'll share that paper with Josie as well. Anything else?
That's it. So thank you for that extremely useful interactive session and Chloe's story. And thank you for the audience for participating as well. So I'm sure we've all learned some interesting nuggets that we can take away into clinical practice. And we'll ensure that we send all the papers so that you guys can have a read of whatever you'd like to. I'm going to hand over to Josie.
Hello, yeah, just wanted to say thanks so much to all the speakers and the chairs. Really appreciate your time, and thanks to the committee who helped organise the day, and again particularly to Alicia who helped organise the speakers and host the Norwich watch party. We're going to send out the feedback link and email form as well, but I think the QR codes are still above. It's not too late to donate, and thanks for an excellent day. Anything else you think of, just feel free to email us at any point. And I think the committee, if anyone's free, are going to stay around for a quick meeting, but if anyone's welcome to sit in if they're interested. Otherwise, feel free to log out. Thank you very much.
Thank you very much for this.